with your hosts, David Levy and Paul Vadiato, who bring you more than a combined 25 years of practical experience, helping thousands of family caregivers, helping them find solutions to the challenges and frustrations presented by this important responsibility. So if you are in the position of caring for a spouse or a parent, a loved one who is no longer able to care for themselves, or if you know someone who is, this hour will be worth the listening. Now, let's tune in to today's edition of Caregiver Reality with your hosts, David Levy and Paul Vadiato.
Good evening, South Florida, America, and the world. It's Tuesday at drive time, and this is the Caregiver Reality Hour. You're listening or watching us on CaregiverReality.com. If you've got the app, iHeartRadio, WWNN 1470 AM, WWNNradio.com, amp2.tv, and eventually everywhere.
CaregiverReality.com.
Didn't I say CaregiverReality.com? I'm so involved with everybody else's that I forget ours. CaregiverReality.com. It'll be up tomorrow. You can see it again. It'll be on YouTube. It'll be on iTunes. Just wherever you want to pick us up on whatever you're using, you can catch it whenever. But it's a beautiful night here in South Florida, and those of you that are still digging out of the snow, sorry, but that's just the way life is. And we've got a great guest tonight, Dr. Barry Taney from the Retina Group of Florida, and we're going to hear some very interesting things, maybe some bleeding edge of what's going on technology and practice-wise, as well as Paul asking his usual inquisitive directives to find out what it is, baseline, that everybody out there needs to know about a retina. And so without any further ado, we will kick on the first question, which is Paul.
Oh, David. My week in caregiving in, 25 words or less?
Yes.
It has, since the first of the year. Yeah, that's a good word. It is the ups and downs. Who's going to pop up today? We've been having a really difficult time with chronic fatigue. Mm-hmm. The same situation with the gastro issues on there. And I was just talking outside before to Dr. Taney and saying, right, it's up and then to sleep again. And Suzette has not been much better, has she? No,
it's been a tough couple of weeks for her since she was in the ER, and then we were back to get some more IV fluid. And this has been a very difficult couple of weeks. It's really been very problematic. And when you have dysautonomia, you never know what's going to work one day to the next, and it's certainly been that way. Today she was feeling a little bit better, but that was before I came here, right? Yeah. It could go 180 degrees by the time I get home. So we never know what's going to happen. And it's made my caregiving job a little more difficult this week because we've had a busy week, Paul, as you know.
We have.
It's only Tuesday, but it feels like a Friday. And a lot of people, a lot of problems out there in the caregiving world. I just came from a support group at Arden Court, who is one of our sponsors. This was their facility in Delray, and 9 people, 5 new ones, and everybody has an issue. And you got to go back to the basics, even though there are some there that are more advanced. You got to bring along the new folks.
Absolutely.
And,
And to our listeners out there who've been following us on Facebook and Twitter, we appreciate the comments that you've been making along the way. And I'd like to pose to you, because I mentioned earlier, I have had a very difficult week in caregiving with this issue of chronic fatigue. So those of you caregivers who are caring for someone with an autoimmune disorder, tell me how you're feeling about it. How are you handling it? The uncertainty of what each day is going to bring. I'm sure you're finding it as difficult as I am, and I'd love to hear your comments.
And don't be afraid to get into the nitty-gritty, because Paul and I certainly, I've been dealing with chronic fatigue and her dysautonomia now for 15 years. And so I have...
You've had a bout of it, too.
Well, I didn't really have dysautonomia.
No, I meant
No.
chronic fatigue.
Chronic fatigue, well, that was a result of a medication I'm taking that just slams me into the wall. But be that as it may, and that's also one of my topics tonight from my perspective.
Yes,
but,
David, what is your perspective tonight?
My perspective tonight is, after looking and doing a little bit of research, and I'm just going to touch on my notes because I hate to read, but my issue is what we're seeing across the nation these days in terms of drugs and medication. We're seeing drugs that do phenomenal things, and I'm speaking now of some of the new drugs for hepatitis C that have come out from Gilead and Abbey, and the wars that are going on between the third-party administrators is who can buy it cheaper, because these drugs are $90,000 and $100,000 for a 12-week course of events. And certainly with the extent of hepatitis C, just as an example, and genotype 1, which is a category of the genetic predisposition in having hep C, makes it, that's the tough one. And to try and get approved for a $94,000 drug is getting very problematic. But yet, when they make their argument of all the time it took to research and bring it forward and what it would cost, excuse me, to take care of somebody through the degenerative process of hepatitis C, including the potential for a liver transplant, you can begin to see some of the argument that's going on. But where we're really beginning to see a problem is, what the heck happened in generics? What happened to our $1 and $2 medicine that all of a sudden is 40, 60, 100 times what it was? There was a time not very long ago, medications like Vibromycin, which was pretty much a standard antibiotic for everything from sinus to whatever else infected you. And you could get it for $2, $3, $4, $5 for a standard course of treatment. Now you try and get Vibromycin, and it's up over $1,000, and that's just unconscionable. So I went to do a little bit of research, and I'll just go through this quickly. Many years ago, back in '84, there was something called. Let's see, it was the Orrin Hatch was one of the senators that, and it was there to try and regulate to some degree and protect patented medicine, so that if you spent years and millions and hundreds of millions, that you had 17 years of patent protection on your drugs. And after that, they could then move into another category called generic, with manufacturers now mainly overseas for the most part, in India and other places, that are now manufacturing the drugs when they come off of patent. But many of those drugs, because a number of the generic manufacturers were producing it, it got down to where there was literally no profit in it for them. So they either chased themselves out of the business to go after newer generics, leaving only one or two people producing it. And all of a sudden, one generic manufacturer says, I'm the only guy making this stuff. I think I'll jack the price up. Mm-hmm. And then you also have other filters that it goes through. All right. We have group buying organizations or group purchasing organizations. We have third-party administrators like CVS and Express Scripts, who just were in the battle over the hepatitis drug, and Anthem. And to a great degree, for many programs, it's what's in their formulary is what you get. And there are distributors and middlemen, and they also call the shots just because it's cheap.
David, you mentioned formulary. Why don't you explain that a little bit?
A formulary is nothing more than either a company's list of what drugs are included if you have insurance from them. So if you're in a Medicare Advantage program, if you're an older person, or you're in an accountable care organization, insurance program, or major medical from your employer, typically if there's a drug program that goes along with it, what's included and what's excluded is considered to be their formulary. So some programs have drug X and others don't. And so many times when people are picking Medicare Advantage programs, one of the first things they look for after are my doctors
Sure.
in the program is, are my drugs covered? Or am I now going to have to, really go out there bare bones and buy it for whatever traffic may bear? And Paul, you're a perfect example. A drug that's generic just cost you what, $250 or $300? That should be no more than a few bucks.
Exactly.
And so my problem is that we have always kind of presumed that free enterprise was going to be the controlling factor, that if a drug came off patent and the FDA approved it as being a bioequivalent, meaning that it had enough of the same ingredients that it essentially did the same thing as the patented drug, even though it might not have the same coating or binder, but it was essentially designed to do pretty much what the patented drug was, that competition would keep the prices down. But now they're wising up and saying, well, if everybody needs vibromycin and we decided to get out of it, and there's only a couple guys left, it might as well be a patented drug when they set the price. And certainly the distributors that have it on their shelves that supply it into the third-party administrators, et cetera, have no problem in raising those prices because it's money in their pocket, and it's a great disservice to the American public. And I think we're going to find that we are going to get into the generic war problems of all of a sudden affordable drugs are no longer affordable, even though they're off patent. And I understand that there is a big conference coming up in Washington, D.C. in the next few weeks to address this issue. So this is one of the things we're going to be watching because it affects everybody, anybody that goes for a prescription. I just had my next door neighbor, and I'll sum it up, who used to brag under her program that she could go to Publix and get a prescription for $2. She went the other day and it was $57, and they warned her that it could be over $100 the next time she comes back. So these are things that we have to watch. We can't assume that what was will be. And medicine is a very important subject matter.
And as a consumer, you have to ask those questions
right,
beforehand.
but when you get faced with the pharmacist coming out and saying, this is what it cost me and with my markup, and this is what your formulary approved, it's kind of like, when the bank officer tells you, you were turned down for the loan, but you said I'd be approved. Well, the bank committee said. And so there's this background of whoever's setting these prices and doing what they're doing that are beginning to become very problematic. So this is going to be a subject that we're going to have to watch going forward. One of the things that I do want to touch upon just very quickly before we go to our first break is that Dr. Barry Taney, who is in the studio with us, he's part of the Retina Group of Florida, and he's been practicing for more than 25 years as a vitreoretinal specialist. And I looked that up, and I can't tell you that I'm 100% on, but they seem to have had a lot more training, and they obviously specialize in the retina. And we had an opportunity to speak with him a little bit before the show, and it's kind of fascinating what they're doing. I can't wait till you get into the questioning. And so, and he's been named one of the best doctors in America, a top ophthalmologist by the Consumer Research Council of America, and was chosen for how to find the best doctors of America by Castle Connolly Medical, as well as the New York Times and the Miami Herald. Now, if I say any more about him, he will not be able to get to the microphone because his head will be very swelled. So I'm going to wait until we get into discussing it with him and we can get into further credentials and more about what he does. Right now, we're going to take a break, and when we come back, Paul and I have a short discussion with you about some of the things that we're doing, and then the rest of the show is going to be Dr. Taney.
Perfect. Thank you, David.
Are you a family caregiver? Are you taking care of a spouse or loved one who can no longer take care of himself or herself? Are you dealing with Alzheimer's disease and don't know what to do? Do you feel burned out, frustrated, and just don't know where to turn? You've tried doctors, lawyers, and mental health professionals and have come to realize that they don't have practical answers to these questions. What you need are experts, non-clinical family caregivers with 25 years of active experience helping thousands of family caregivers like yourself. People who can help you provide a better quality of life for yourself and your loved one. Who you need are David Levy or Paul Vadiato. Reach David at david@caregiverreality.com or reach Paul at caregiverreality.com and let them help you pick the right path towards improving the quality of life for you, the caregiver, and your loved one.
This is Paul Vadiato, co-host of Caregiver Reality Hour. As a spousal caregiver, I know that sometimes things get rough and sometimes we lose perspective. David Levy and I have over 50 years' experience and expertise on advising caregivers. If you find that you need help, you're a little confused, reach out to us at Paul or David at caregiverreality.com. We're there to help.
This is Caregiver Reality with gerontologist David Levy and caregiver expert Paul Vadiato, who ask you to call in and speak with him on the air toll-free at 888-565-1470. That's 888-565-1470 to share a story or important information. Now, back to today's Caregiver Reality Show.
And we're back, and very soon we're going to be talking with Dr. Taney. Paul and I have had a very interesting weekend besides caregiving. All of a sudden, people seem to be coming out of the woodwork. When we came in today, Freddie kind of informed us that we may be one of a few chosen programs that are being looked at for the potential to go on the tube. I'm not allowed to say with whom yet, but that's pretty exciting. I'm sure if she were alive, my mother would be very proud, as would yours, Paul. But that's an exciting step. If we can grow from what we're doing in radio and streaming media and also have a presence on the big box, even though you may watch it on your cell phone or your computer. I mean, right now, in this world of media, we have to be ready to get you what you want, when you want it, and where you want it. And it's no longer that, we're lucky we're on at 5 o'clock drive time, but half the world that hears us isn't drive time, nor are they listening. But sometime during this week, they will connect with us in one of a myriad of ways. This show is merely what Paul likes to describe as the small end of the megaphone that feeds it out there, and then it's wherever it goes, and that's been responsible for our footprint growing and where we hope to take the program, including very recently Paul's very exciting new turn of events called Engage for Change, which is advocacy for caregivers everywhere. And Paul, why don't you just give us a few words about that?
David and I started talking about this towards the end of the year. And for us caregivers, and there are over 60 million of us here in America, really are invisible and silent most of the time. We're busy doing the things that we need to do, and we're just not being heard. And we really believe that this needs to change. So we started a movement called Engage to Change, Advocacy for Caregivers Worldwide. Be a change maker. And that's what we're asking all of our care makers to do, is to get the word out that we need more education, we need more training, we need more support groups, and we need more money to make these things happen. All across the spectrum, whatever the disease may be, there is going to be caregivers, from addiction to alcoholism to autism and everything in between. You're out there in the fields day to day carrying the torch. We need to get help, and our voices need to be heard. So please write into us, Paul at caregiverreality.com. Go on to Facebook, go on to Twitter, and say, I'm engaged. And when we get enough people, that voice will be heard. David?
And I think it's very important. There have been, there have been a lot of people that talk about caregiving. We're trying to do something about it, raise visibility, because it's one thing when we raise dollars to try and cure a disease. But while that's happening, there's somebody at home that's in the trenches 7/24, untrained, unaware, needing help, the potential to burn out, who don't know where to look or how to go about it. Some of these diseases that they're involved with are very complicated, not just from a medical perspective, but how do you deal with it emotionally when it's a family member, etc. And these are the unsung heroes. And if tomorrow just 10% of the caregivers just in the United States were to wake up and say to the formal healthcare system, I've had it. I'm not doing another thing. You do it. We would be looking for 6 million caregivers and trying to figure out how to interface them, for the most part, in people's homes. And it just wouldn't work.
Sure.
It would probably roll the healthcare system over. And we have relied upon the informal or the unpaid family caregiver for years and years, assuming that because they're a family member, intuitively they know what to do.
Well, they're going to step up now, and we're going to get some help for them and have their voices heard.
Right.
Tell us a little bit more about Dr. Taney, David.
Well, pardon me if I have to read just a touch. This man is so full of credentials and good stuff that it's amazing.
I hear he's a good golfer, too.
Okay. He's past president of the Broward County Ophthalmology Society, the American Academy of Ophthalmology, the American Society of Retina Specialists, Palm Beach and Broward County Ophthalmology Society, and the Fort Lauderdale Caducean Society, and is fluent in Spanish.
Correct.
Okay. Vitreoretinal retina specialists are ophthalmologists specializing in the treatment of retina diseases, including age-related macular degeneration, retinal detachment, macular holes, diabetic retinopathy, and complex retinal diseases, including advanced retinopathy of prematurity, cancers of the eye, complex surgical disorders, as well as genetic eye diseases. For those of you out there that didn't follow all of that, that's okay, because neither did I. But it sounds very, very important. And, Doctor, welcome to the show. Paul?
Thank you. And Dr. Taney, thank you so much for being with us today. You're coming from the Delray office today?
Yes, I am. We have offices all throughout South Florida, and this one was just opened recently, actually this week.
Oh,
Congrats.
congratulations.
We offer services of retinal diseases throughout South Florida.
Well, we appreciate you taking time away from the family and the practice to be with us.
And the boat.
And the boat.
Right.
Let's really start at some very, very basic things for our audience who may not be as sophisticated in all of the things that David just elicited. Talk a little bit, if you will, about the retina and what it does, and without the medical 101, why is it so important?
So the retina is basically one of the most important parts of the eye. It acts as the camera and the film. And so if you think of the eye as a camera, with a lens, which would be a lens which is in the front of the eye, the cornea, which covers the lens, and the retina lines the entire back part of the eye, acting as the film of the camera. It receives light impulses and chemically transmits these light impulses to the brain and creates a picture for us. So the retina basically is extremely important. If it does not work, the camera doesn't work, the eye doesn't work, and people have vision problems.
Thank you. David listed a whole host of diseases that the retina and the specialists at Florida Retina Specialists deal with. Talk a little bit in very generic terms about what are some of the problems that you see day in and day out.
Right. Doctor, I need you just to get a little closer to the microphone.
Okay.
Thank you.
So,
because it's too important to miss.
You were talking about caregivers, and we deal with this all the time, probably very frequently in South Florida, more so than other parts of the country because of all the retirees. We deal with macular degeneration, which is a deterioration of the central part of the vision, making people's vision difficult, with difficulty in reading, seeing faces. And one develops blind spots or pieces of the picture missing. So simple things like reading, driving, watching TV, seeing a loved one's face all become progressively more difficult.
Is that almost like when we see on a television screen it gets pixelated and you can't see it, or is it actually a black hole?
It's more, well, in the worst stage, it is actually a black hole. But the best analogy would be if you took some Vaseline and put it on your glasses.
Oh, yeah.
And you see a smudge. And that's how it starts up. And we deal with macular degeneration day in, day out. And we have a lot of family members bringing their loved ones in who are becoming progressively more feeble, more disoriented, having more problems with life as this disease progresses. We also deal with diabetes, which, if untreated, can cause similar problems with this blurred vision and actually loss of vision in the advanced stages of the disease. We deal with retinal tears when people have floaters and flashes. We hopefully can see them before they develop a retinal detachment, which would be the next stage of the disease after a retinal tear develops.
Doctor, floaters and flashes, give our listeners an understanding of what that might look like.
So a lot of people say, I was driving and all of a sudden I saw a shower of bugs, or I could have sworn there was a bug in front of my vision.
Great.
And I tried batting it away and it wasn't there. And sometimes it spread out like ink in a glass of water.
You mean
and murky.
Yeah.
And other times I had it for an hour, for a day, for 2 days, and it went away. So I didn't think much of it.
Right.
And
Sure.
by the way, all of my friends told me, oh, I had that too, don't worry about it. It can also be associated with flashing lights, which signifies pulling on the retina. And that is more worrisome because that's often associated with a retinal tear.
I see.
Wow. David, do you have something?
Well, as far as, we always come and see people, it's like caregiving, when their hair's on fire, when all of a sudden our vision has gotten a lot worse. And so most of us that wear glasses and we traditionally go to the optometrist who tells us whether or not, our eye pressure is good and what it looks like. But in a more preventative sense, what can one do, if anything, proactively to kind of stave off some of those retina degeneration issues, if you can?
Well, lifestyle is always the most important thing. Eating well. Smoking is a definite risk factor. If you're out in the bright sunlight, wear ultraviolet blocking glasses. Eat a lot of vegetables, green vegetables in particular, not a lot of fat. And for people who have been diagnosed with macular degeneration, a certain subset of those people will do better with specific vitamins.
Okay. One question, because my father had it. Is it inheritable? Is it a genetic pass along, or is it luck of the draw?
I read a statistic recently that if your parents had advanced macular degeneration, there is almost a 50% chance that you will have some form of it.
Another gift from Dad.
Exactly. If your parents didn't have it, there's only about a 10 or 12%. But as one gets older, for the age group 60 and older, 10% of people have macular degeneration. And as one goes up to 80, it goes up to about 30%.
Pretty high. Your practice is a physician referral practice, and that's a relatively new term. Can you describe what that is, how do we get in to see you?
So the field of retina surgery and disease is a relatively new field of medicine. It's been around in the scheme of things for about 30 or 35 years. And we see people who know they have a retina problem or look up on the internet their symptoms and figure out that they have a retina problem. But more importantly, we see people who are referred by optometrists who are very competent in diagnosing these problems, and ophthalmologists. So they will make the referral. Also endocrinologists and rheumatologists.
Diabetes specialists.
Yes, diabetes specialists and people who specialize in arthritis because certain arthritis diseases cause problems in the eye. So it's a broad spectrum of
That's a
of
very
referral
interesting
sources.
piece of information. That the rheumatoid arthritis or just arthritis in general?
More rheumatoid arthritis and more specific, rarer diseases.
Okay.
Well, I know for one of the medications that Debbie takes, she has to get field of vision tests done twice a year. So it is important.
Right.
All of the doctors at the Florida Retina Institute are board certified, and we see board certified, I guess,
In lots of
lots
disciplines.
of fields. Tell us, what does that actually mean? And really, for our listeners out there, why is it important that they search out those type of doctors?
So board certification is just another quality indicator that you've met some rigorous standards as far as your training and basically passing very thorough written and oral examinations with examiners.
Mm-hmm.
Now, there is, interestingly, no board certification for retina.
Just
But
for ophthalmology?
Just for ophthalmology.
Huh.
And that's a long discussion in itself. But there are certified vitreoretinal fellowships. So a retina specialist does ophthalmology first, gets training and board certification in ophthalmology, and then goes on to do training in vitreoretinal surgery and
typically,
disease.
how many years is that, doctor?
It's a total of, after medical school, 6 years.
Wow. And didn't you tell us outside that your daughter has
Yes.
just become is a
Yes.
retinal specialist?
Yes, I guess I did something right. Yeah, my daughter, when she was young, we would see emergencies on the weekends, and she would come into the office and say hi to the patients and kind of stand in the back and saw what was going on. Anyway, she decided to go to medical school and fortunately decided to do ophthalmology, and even more fortunately decided to do retina. So she just finished her fellowship and just started her practice 2 months ago.
Oh, but you said she's not a part of your practice. She's up in Washington, you said?
No, she's in Washington, D.C.
All right. And probably for a while that's a good thing.
We'll see.
All right.
Well, it's good to
But-
it's good to
You
have
know, it's
an
good to
instant
hang out with
consult.
Dad,
Yeah,
of course, but
Right, we go to conferences together. She calls me for opinions about cases
all right.
and sends
Well,
pictures.
nothing like Dad for a
and-
second opinion.
Yeah, it's great.
That's great.
the technology has changed so dramatically, and I know especially when you're talking about the eye, you're really talking about small places and difficult things. Tell us a little bit about the technology that you use in your practice.
So ophthalmology, by necessity, deals with very small spaces, from cataract surgery to retina surgery. And the field of retina really, as I said, has only been around for about 30 years and basically grew with the invention of small micro instruments that are placed into the center of the eye. And these instruments illuminate, they cut things, we're able to grasp things, really working at the level of microns. The retina is only about 200 or 250 microns. That's a quarter of a millimeter thick.
Wow.
And we have instruments where we can go on the surface of the retina and peel things off of the retina, grasp foreign bodies. If somebody's in a car accident, we can go and take things out of the eye that are underneath the retina. So it's really it's quite a advanced field. We have
Needless to say, you have a steady hand.
yes, hopefully. We have instruments. The most exciting recent one is a instrument called OCT, which is basically optical coherence tomography. And what it does is it shines a light beam in through the front of the eye, reflects it off the back, and then a computer processes the information and is able to do an optical cross-section of the retina.
Wow.
And the resolution on that is about 10 microns. So with that, we're able to fine-tune our diagnosis of the diseases and the treatment of disease.
So you see things deeper into the retina than you heretofore might have been able to?
We see things deeper within the retina, and we see things that are within the retina much better than we were able to just with the naked eye.
That's amazing.
Wow.
It really is.
All right. I
And
think
we tailor our treatments for in macular degeneration and in diabetes and in surgical planning using this instrument. And recently there was a further refinement of this instrument. I think it was just FDA approved, where you can attach this instrument to the microscope when you're doing surgery in the eye, and it will help you
wow.
make good surgical decisions.
I think when we were talking outside earlier, and I said to you, is there a Da Vinci machine, which for those of our listeners is kind of a robotic surgical instrument. It's being used a lot these days in laparoscopy and micro-type surgery. But you said that more than likely the Da Vinci machine came out of what was going on with these micro instruments that were being placed in the eye by specialists like yourself.
And by necessity, we had to get into small spaces.
Right.
And we used small illuminated fibers and small instruments, and we do it the same way the Da Vinci machine does it.
All right, so the
except
light
we
went
don't
on
have
for
robots.
somebody.
And there have been experiments with robots for the eye, but so far nothing.
All right. Still takes the doctor's hand and eye.
Still,
Huh?
correct.
Doctor, you mentioned earlier about people experiencing floaters or incidences in their eye that come and go. Tell us a little bit about what they need to be looking for and when they really should get to the doctor, and when should they take this a little bit more seriously?
Well, the normal aging process involves shrinkage of everything in the body. Changes in the skin, changes in the collagen, and the center of the eye is filled with a jelly called vitreous. And the vitreous undergoes changes and goes from a nice, smooth, gelatin-like material to more of an egg drop soup material. And
For those of you who are Chinese food eaters.
correct. And as it goes what we call this liquefaction, becoming more liquefied, it shrinks. The problem is that the vitreous is attached to the retina. It's almost like a soft-boiled egg, where the vitreous is like the yolk of, of the egg, and the retina is the white of the egg, and it's attached. So as it shrinks, it rips the retina, and that's what causes retinal tear and retinal detachment. So if somebody, especially if somebody is nearsighted, they're at higher risk. If there's a family history of retinal detachment, they're at higher risk. But if somebody does develop floaters, I think it's a good idea that they see one of their eye care providers.
Okay, well, that's probably good advice anyhow. Normally, we see our optometrist if we have glasses, but it's probably a good idea to have an annual eye checkup regardless.
I think it's a very good idea because there are certain diseases of the eye that sneak up on you, such as glaucoma. It's only at the advanced stages of glaucoma, when there's loss of your peripheral vision, that you even know you have it. So that's very important. The other thing is people, as far as the retina goes, when they develop things like macular degeneration or diabetes, they say, I just need a new pair of glasses. But really, that's not the case, because glasses won't fix the problem. It's a problem with the retina or the receptors. That's the problem. And therefore, if somebody's vision is not good, or there's a change in vision, if there's distortion of the vision, it's important that one sees the eye care provider.
All right.
And take it seriously.
And take it seriously.
Well, you only get 2 sets in one time around with them, as far as eyes are concerned.
Speaking about caregivers, as people get older and they become less communicative, they often will have these issues, but they won't communicate.
It's not articulated.
Correct.
All right.
And the caregiver will come in and say, just not doing this or not doing that. And then a big problem is found, but the more elderly person won't articulate that.
Right. And so caregivers have to be not only reactive to what they see, but proactive and we're talking now about a caregiver for an older person, has to be proactive for some of the normal diseases of aging, especially related to eyes, because that's an essential quality of life. And your connector, when you are not necessarily hitting on all 8 cylinders, still to be able to read, watch, hear television, whatever it may be, and you lose that eyesight, it's gone.
Well, let's follow up with that. Fear obviously has to be inherent for all of us that would have difficulty in seeing. You use the word blindness, it's permanent. How do you address that when somebody comes in and they're very fearful about what's going on? Talk a little bit about that.
Everybody's very fearful when they have eye problems, especially people who have had a problem in a fellow eye and can't see well, and then their only good eye begins to develop problems. And I think it's just a question of being very calm and reassuring the patient that we have a lot of tools at our disposal which we did not have as early as 5 or 10 years ago, which we can now use. The drugs that we use to inject in the eye are much better. They were actually non-existent before about the year 2000. The instruments that we use now are the size of a little more than a hair, but they're very, very small. We use micro-incision surgery now. People heal very fast. We can do a lot of things with chemicals which we use to hydraulically attach the retina, which were non-existent in the past. So even though when you have a retina problem, it's a significant problem, there should always be hope.
And I think really the takeaway is so much more can be done today than not that many years ago.
Absolutely.
So if you were kind of written off a couple of years ago, it might be a good idea to go back and see what the science, et cetera. You're giving me that maybe so, maybe
so.
No.
Basically, there's a time issue with a lot of eye problems. So what you lose, often you can't get back, which is why it's important to be proactive,
right,
as you said.
All right. When we were sitting outside earlier, I said to you, what was the Caducean Society of Fort Lauderdale? And you told me what it was, and I found that to be kind of fascinating. Could you touch on that?
So the Caducean Society of Fort Lauderdale was founded 35 years ago by a group of doctors in Fort Lauderdale who were interested in learning about the other's field. And one of the issues when you are in a very subspecialized specialty is that you tend to have blinders on. You don't really know what's going on with the rest of medicine. And that's not great, because the part about being a good doctor and a complete doctor is to know what's going on with the rest of medicine. And you know what? You might get a good idea that you can apply to your patients. So basically, it's a group of 30 or so doctors that have dinner once a month, and everybody gets together and they go around the room and you stand up and you talk about what is new and exciting in your field for a few minutes or 5 minutes.
That's a great idea.
That is, I think that's wonderful. and
It's very stimulating, and it's what medicine really should be about.
well,
David,
I
from-
applaud that effort.
Many of our listeners, as you know, are in rural areas or they're not so accessible. And we're really talking about a very unique specialty that Dr. Taney is involved with. This is the kind of a thing that if these kind of problems exist and your ophthalmologist is giving you this advice and saying this is the issue, these are the kind of doctors that you search out. You come to a place like the Florida Retina Institute, you search out those specialists that are going to be able to do this. You only get one chance of getting your sight.
Well, you're absolutely correct. And doctor, besides you and your daughter, how many retina specialists, vitreoretinal specialists are there? Even though we don't have a board certification that kind of aggregates them, but
I actually would have to look that up, but the largest organization in the world of retina specialists is called the American Society of Retina Specialists, and I think it has, at my last count, which may not be totally accurate, somewhere about 2,500 members.
so if we were to spread them out equally, that's only about 50 per state.
Yes.
All right, and obviously they're aggregated in urban areas a lot more than they are
That's very
in
true.
rural areas. But if somebody has been told that their eyesight, which is critical, is being compromised by a retina issue, etc., it would probably behoove them to go and seek out. Is there a directory from that organization of
there-
where specialists are to be found?
There is a website, and I think there is something on the website where you can find a retina specialist near you.
Okay. Do you do any telemedicine in terms of consulting? I mean, do you get on the internet perhaps and at least give somebody an understanding of what they may have, even if they can't get to you?
The answer is not formally, but there are people who are exploring the application of telemedicine, and the images that can be captured with devices now and transmitted over the internet are quite good. Although
If you don't have
It
the
goes-
hands and tools
it goes
to do
back
it,
to the
yeah.
old saying: if you have one image, it's only a piece of the puzzle.
Right. And
So
quite frankly,
it's
even if you've told the ophthalmologist in Podunk what's going on, if he cannot perform the surgery or if there's nobody that's in the area, it's information.
Correct.
And,
But
right.
there have been studies that have shown that there is a future for telemedicine, that the pickup rate is very significant.
All right.
Plus
Well-
the flow of information. People
Well, but
realize it.
when you stop to think about this, what was it,
OCT.
OCT?
Yeah, those can be transmitted over the
Right,
internet.
and so that image should be transmissible, and so I guess that allows specialists like yourself at least to weigh in
Correct.
for somebody that may not have
Correct.
that knowledge, and at least give some good advice, including get out of Dodge and
Correct.
come to Florida.
Yeah.
Dr. Taney, if I had been referred to you by my ophthalmologist, what is it you'd like to see me and perhaps my caregiver, if I had a caregiver, bring to the office, and what type of questions should they be asking?
Well, the main thing really is to bring yourself.
Right.
We always would like to have a medical history, know what drugs you're on, because there can be some drug interactions in the eye. We'd like to know if you are on blood thinners, because certain bleeding problems in the eye can be aggravated by blood thinners. There are some toxicities of certain drugs. And we'd like to know from the caregiver how the person's behaving. What does the caregiver think the problem is?
All right. Well, that's a very good first start. all
Boots
right?
on the ground.
Boots on the ground is absolutely, and as you said, you got to bring the eyes in, but having somebody that can also illuminate or be clearer about what they may be experiencing if they, for argument's sake, because of dementia or some other issues, can't articulate clearly. I'm
Correct.
sure that it has to be a little bit back and forth of,
Correct.
just from the old click, is this clear or is that clear?
Right,
If you don't say yes, it's kind of hard to fine tune it.
So we make an appointment, we visit the office. Typically, it would be about a consult first, and then a course of procedures or action.
Correct. You come into the office, we take the vision like anywhere else, we check the pressure, and then we see you and examine the eye with a dilated exam, which is critical to really know what's going on. And it's most important what's at the other end of all that equipment, trying to figure everything out. And then we can do tests called OCT. We do a test where we inject a dye into the vein of the arm, which allows us to check out the circulation of the retina. We can see if there's something growing underneath the retina. We can see if somebody has a tumor, what the blood supply is to that tumor. We can evaluate with a new technique called autofluorescence, which is a special infrared camera, certain reflectance patterns to the retina, and hone in our diagnosis.
Wow. So I guess as science improves and the technology advances, it gives you a greater opportunity then to fine-tune what you need to do, and it
Correct.
probably saves a lot of what earlier may have been, respectfully, a little bit of hit or miss. It's much
Correct.
more finite and precise.
Right, and I think the key word here is that it's a very objective assessment of what's going on, where there's still the art of medicine, but we have with us a lot of tools that make it
The science of it better.
Much better.
All right, I didn't mean to finish your sentence. I apologize.
And most of the procedures that are done, or what is done in the office, is usually they go home the same day.
Correct. Most of the treatment that we do for macular degeneration and for diabetes is done in the office with either injecting chemicals into the eye or lasers, which are done in the office. If somebody requires a surgical procedure for advanced diabetic retinopathy, or a hole in the retina, or scarring of the retina, or a retinal detachment, then they have to go to the operating room. It's done as an outpatient procedure 98% of the time. It's usually done under local anesthesia, more often nowadays in a surgery center versus a hospital, and the patient goes home a few hours later.
That's
Wow.
amazing. And what about the caregiver in terms of aftercare?
The aftercare in retina surgery is fairly easy, except for one thing. And sometimes we put gases in the eye to blow the retina back into position to allow the retina to heal, in which case people have to position sometimes. So we'll say either look down, or lie on your left side, or lie on your right side, or sit up. The idea being that we will float whatever we put inside the eye
Back into position.
To reattach things and let things heal.
Right. That's not so easy with somebody who's
It's-
a little bit
it's-
older and may have
that's
some
correct.
cognitive issues, et
Correct.
cetera. So,
And we actually have, we use, it's called silicone oil for cases like that where somebody can't position, where we actually fill the eye with a bubble of silicone to just keep everything in place. And that can either stay there forever, it's crystal clear, or we remove it a few months down the road.
could it be a substitute for vitreous humor?
The vitreous is a substitute for vitreous humor, and the vitreous is really only necessary for the formation of the eye
I see.
when you're an embryo.
Okay.
Once you're born, everything that was going on to form the retina and to form the lens and to form the iris, the eye is filled with a mound of blood vessels, and as you mature and reach gestational age, or when you're born, that all regresses.
I
And
see.
the vitreous is just a clear jelly.
Gotcha.
So you can remove it and not have any
Negative
Negative
consequences
effect.
per se.
correct.
Okay. Your eye won't collapse.
Yeah.
David, believe it or not, we're rounding out this
Wow.
hour. It has gone so quickly. Dr.
We have
Taney,
to have you back. 'cause
Yeah, for sure.
I have a slew
My
of
pleasure.
questions.
But before you do leave,
Yeah.
what would you like our listeners to, as a takeaway, to retain? What would you like to tell them?
What I'd like to say is that eyesight is precious, and good vision shouldn't be ignored. People love to procrastinate.
Oh,
And
yes.
say, oh, yeah, it'll go away. I don't have to do anything. But if there is something going on with your vision, it's much safer and smarter to go see somebody who's qualified to assess it. And if it is nothing, well, then that's great. But if it is something, the earlier it's dealt with, the better the outcome.
Great. And so I'll ask Paul's question. If somebody wants to get a hold of you at the practice, what's the number? Because Sharon wants me to make sure that everyone knows how to get a hold of you.
We are on the internet, Retina Group of Florida. I think it's rgfla.com. And we have offices in Fort Lauderdale, Hollywood, Boca Raton, Boynton Beach, Palm Beach.
Okay, so
up and down the coast.
you're everywhere that somebody needs you to be.
And I don't remember every number.
You don't have to, but
And there's an event coming up, David, on Saturday the 31st, Foundation Fighting Blindness annual seminar for low-sighted and for patients and caregivers, and it's at FAU in Boca Raton. And I understand 4 of your doctors are going to be there.
Correct. We've partnered with the Foundation for Fighting Blindness for well over a decade. And our group has been involved in over 50 clinical trials, some of which have resulted in drugs which have really revolutionized retinal care.
well, Doctor, I'd like to thank you. That song in the background is saying sayonara.
Okay.
It's been a fascinating, fast hour. You've really filled us with a lot of very good information, and I think our audience will greatly appreciate it. And Paul, you've got some great guests for next week.
We do.
And so tune in next Tuesday, Drive Time, Caregiver Reality Hour, and we promise you will not be bored, and you will learn something that you can definitely take home and use. And so to everyone, good night. And Paul?
Good night, David. Good night to our listeners and caregivers. Take care of yourself.
Thanks for joining us for this week's Caregiver Reality Show. Each week, David Levy, a gerontologist, and Paul Vadiato, a caregiver expert with a combined over 25 years of experience, providing practical and realistic help to caregivers struggling to keep up with the needs of a loved one who are unable to care for himself or herself. To reach David Levy, email him at david@caregiverreality.com. Or to reach Paul Vadiato, email paul@caregiverreality.com. And find out more online. Just go to caregiverreality.com.